Jean Hawney. I am a pediatric speech-language pathologist here in Houston, owner of Little Eaters and Talkers. And today I have Kelly Komisaruk, right? I said that right? Okay, with Food for Thought, who is in Orlando. And today we are bringing more awareness to ARFID. And I am so excited that Kelly is here to educate us all, parents, other clinicians, on ARFID because it is often very confusing. It is also in my area kind of becoming a hot topic. I think I'm finding more self-diagnosing of ARFID, and so we really hope that this episode can help you. So I want to welcome Kelly.
Thank you. That was a wonderful introduction. And yes, I do think it's kind of a hot topic at the moment, just in general, which I'm glad there's a lot more awareness being brought to it.
But in regards to like the hot topic part, I think I'm seeing more older children, who are out of the picky eating phase. And parents need a reason for why their child is being so selective. And so that is often why I think parents find out about ARFID and then assume their children have ARFID.
That is true. And it's also oftentimes a later diagnosis, or it can be after several failed therapies at more traditional feeding therapy that they kind of start going down the rabbit hole and sort of find, oh, this could be something more, this could be ARFID. And then it's not usually until a little bit later in life. I do have some littles that have a diagnosis, but usually it's a preteen to young adult diagnosis.
Now, where are you based out of?
I'm in a suburb.
Okay. And do you see clients in the office?
So yeah, I have a brick and mortar. So we see clients in our office every day for feeding. We're about 90% feeding. And we do also run an intensive feeding program through my office as well that we run for six-week intervals at a time. That isn't for ARFID specific, but that's for intensive feeding.
Okay, I definitely want to make sure we learn more about that. And what made you get into seeing children with feeding disorders?
So, I've always been into the medical aspect of speech pathology, and I worked in hospitals. And, in the hospital, you're kind of like doing a lot of swallow studies and you're learning about aspiration, things like that. So when I started seeing more kids that looked like, at that time, and this was years ago, what people might have just called like behavioral feeding or just like food refusal, I was like, well, I'm not sure what to do here, right? Because I was used to kind of doing, are you able to swallow? And this was a totally different thing. This wasn't a skill thing. It was more of a avoidance or refusal, things like that. So I took every single course you could ever imagine, and I was really lucky at that hospital. There was an occupational therapist that was a little bit more my senior, and she had done tons of feeding, and she brought her whole sensory aspect to my training. And I had a lot of the oral motor piece, but we blended those to build a feeding team at that hospital. And then we also had a dietitian on our team and a GI physician on our team. And I learned a ton from the GI physician, what to look for, what might be more medical-based, what isn't looking medical-based. And then later, as the kids got older, and I was like, oh my goodness, this kid seems really anxious around food. What in the world is going on? We had a psychologist that had specialized in a different area of the country in teenage feeding disorders, specifically ARFID. And this was years ago, so it was really new. And she came on our team. And so I was able to learn sort of the anxiety aspect from her. So I had a pretty well-rounded education with it.
Can you tell our audience what ARFID stands for and some of the red flags that you typically see?
So ARFID is a really, really kind of long term. So it's Avoidant Restrictive Food Intake Disorder. So it's very hard sometimes to weed out if it is just general picky eating, which is still something that can be treated with therapy, or if it is ARFID, which is considered a actual mental health diagnosis, right? So with ARFID, you see so much more of that anxiety and so much more of like the, oh my goodness, I can't even imagine taking a bite, or I need to eat alone. I can't eat around all these people. I'm socially isolated, things like that. Versus picky eating sometimes just looks a little bit more like, I'm refusing this food. I'll eat it one day. I won't the next. Parents are frustrated because they can't get consistency. But, if and we don't always advocate this, but if a bribe is offered or a reward chart, we can usually kind of get those kids to taste stuff and try stuff. With ARFID, it is like, no. I worked with a teenager that was 16, and his dad was promising him a whole new brand new setup computer, like really expensive gaming computer, if he would go through feeding therapy and complete these things. And that doesn't work. So, if there's not that intrinsic motivation and that intrinsic desire to change, that's not going to work.
No, that's totally true. I think some parents really don't get that. Or they're so desperate, right? And they're still they still won't do it. They're stubborn. That's what I always get.
Behavioral stubbornness, and it's not. It's just like if you had a fight or flight fear with snakes or with flying, like you have to work through that anxiety. It doesn't mean you avoid it. That's the wrong advice. It doesn't mean you don't face it. You just have to understand that it does come from a place of anxiety and not from a place of stubbornness or manipulation.
So how do you find that a child who, maybe was labeled picky eating eventually gets diagnosed with ARFID?
How do they actually get diagnosed?
Yeah.
What steps? So usually you have to go through to a mental health provider to get the actual diagnosis. People like us, like speech pathologists or really awesome feeding experts, we can kind of guide you like, hey, this really looks like ARFID, but we really shouldn't be the provider that's diagnosing. You can come back to us once you have that diagnosis to get treatment, and we can also treat you without a diagnosis. But I do encourage all my families to seek that diagnosis if you're thinking that's what it is. I think the diagnosis personally is important.
Why is that?
Well, for one, it gives you a lot of protections, and it can give you a lot more kind of ways to get help and means to get help, whether that's a school setting or if you have to integrate it into a 504, something like that. The other thing is I just think for validation, like picture you're a 15-year-old that you're like, nobody understands this. If you do get that actual diagnosis, it's not a justification to not eat, right? But it just validates that there is something going on and that I'm not crazy, I'm not doing this on purpose. There is something more. So I think that that's just important for the.
How long until you say we need to refer out for additional support?
So that's a really good question. And of course, it depends on the child. If I suspect ARFID or if there is a diagnosis of ARFID, I always like to have mental health on board. It doesn't mean that it needs to be something that the child is seen 3 times a week or or an inpatient program, but it is really hard to handle all the anxiety, even if you've had a lot of training in it. It's really hard to, as a speech pathologist or somebody not in the mental health world, to handle that completely on your own. And it's also a little bit outside of our scope. So I think if you can have, you understand feeding therapy, exposure therapy, all those things, if that child can also have a counselor to speak to about the anxiety piece and you're able to talk to that provider, that's the best type of care, is when your providers can communicate, but they're still getting help from both places.
And do you have, I'm sure, but people probably from all over come and find you. Do you have your network of mental health counselors that you often talk about or refer to so that you kind of know their process and be better collaboration? Would you say you do?
I
have your network,
two
right?
in my area. I do, yeah. I have 2 in my area that I refer to very, very often. And we have a really nice back and forth. And a lot of my kids see those mental health providers. I also will, if a child has a person that I've never met before, of course, I'll reach out to that person after a release is signed. Hey, could we talk about so-and-so? And then there is something online called the ARFID Collaborative. I don't know if you know what that is.
I've
but
never
that's
heard of
a
it.
really awesome website. Oh, you should look it up. It's so cool. It's called the ARFID Collaborative, and they have a huge database, and it's split into, I believe it's 4 different groups. It's like ARFID dietitians, ARFID therapists like SLPs or OTs, ARFID psychologists or psychiatrists, and ARFID MDs. So, and it's like you can filter it depending on what state you're in. So I often will refer to the ARFID Collaborative if I need somebody outside of my area.
What do you often suggest for the parents or the caregivers who are involved?
So it can be really daunting and exhausting. There's usually, by the time they see me, there's been a lot of, I don't want to say misinformation, but there might be a lot of infighting between grandma says one thing, dad says one thing, so it's kind of what I'd like to do to start is get like everybody on the same page. And we always start an evaluation in the first sessions with building rapport, not just with the parents, but with the child too, or the teenager too. And then within the first couple of sessions, I like to have a roadmap. Like, this is where we're going, this is our plan, this is what we're doing. So everybody knows. So it's not like we're just picking randomly what we're gonna do each session. I like to have it kind of laid out in front of me what the plan will be.
Could you give maybe an example of what a roadmap might look like? Like if you have a patient that comes, a preteen or a teenager who really is very selective and that they only eat a couple of foods, that's the only foods they eat. They're seeing a counselor, they're nervous, anxious about trying new foods. How do you plan your roadmap for those situations?
So that's a really good question too. So usually my roadmap involves what I do first is get a really good relationship with that child. That's really, really important because if they don't trust me, then they're not going to feel feel safe doing anything with me. So the first couple sessions are usually just us getting to know each other. And then as we're doing that, and obviously I've already ruled out GI issues, I've already looked at oral motor issues, I've done all that already. So once we're on to like this roadmap part, what we're doing is really building that rapport. And at the same time I'm doing that, we're usually building like a hierarchy of foods. So not foods they've done, but foods that they're more interested in trying than others. And this sometimes takes a while. And sometimes you'd be surprised. Kids with ARFID are like, I can only name like 2 fruits, right? So you have to kind of go into like, okay, these are all these things that you've never been exposed to before. So maybe, you know, just pretend like watermelon. Okay, so it's really juicy. So do we think this would be food higher on the hierarchy? Like, yes, I'm interested in trying that, but I'm scared. Or really, really low, like, I don't want that even brought up in therapy again. So we try to get like 15 to 20 foods that we're going to be doing throughout the course of our treatment. But I really want the child's input is into like, yes, this is higher up versus no, I don't want to do this at all. Some ways I generate that are usually like, hey, what do your parents have at home where the smell doesn't offend you? Or when you're at school and you see like someone brought pizza, I know it's hard for you to eat it, but like, does it smell good? Like, does it look good? Do red fruits look yummy? You just can't bring yourself to taste it. But does it look like something you'd love to like just be able to taste without that fear?
I totally agree. Oftentimes when parents say, okay, what am I going to bring to my session or for the evaluation, what foods am I bringing? I'm like, ask your kid. Like the only way is to empower the child, right?
Yes, exactly. They have to have some type of buy-in and some type of intrinsic motivation. So I do share a lot, you know, that motivation and that want to change is a pretty important part of therapy. I don't think that parents want to hear that, but if your child has zero desire to change, doing any type of feeding therapy is going to be very, very challenging.
So on that, because I get those patients where the child they're just not ready yet, right? And sometimes you'll see in 6 months, they might come home and say, you know what, I'm ready to try those blueberries. Will you tell parents, let's hold on therapy, bring the conversation up with your child and see if they change their mind, or will you start the process anyway?
So I do use a kind of a hierarchy again. It's what I call like steps to change. So I go through that with the parents, and a lot of times we all want to change, but you have to be at the right mental spot to really want that change to occur. So for example, I'll take parents through it and I'll say, pretend, I mean, most people are like, yeah, I've wanted to like lose weight in my life, right? So I kind of use that as an example. So you could be at a place where you're like, I'd really like to lose weight. I see the value in it. I see that it's healthier for me. I see that it would make, you know, my quality of life better. That's where you're kind of like, I'm ready to do it, but I'm not ready to take the steps to do it. Like, are you ready to wake up at 6 a.m. and go to the gym every day? That's the step that your child needs to be in to have successful feeding therapy. Your child might kind of say like, hey, I see the value in changing. I see this is restricting me. I see this like is hurting my growth or development or kind of ability to go to birthday parties. But they have to be at the point where not just that they're recognizing that, they have to be the point where they're like, I'm ready to do these hard things in order to make the change. And a lot of teens aren't. A lot of teens are. I have great success with those who are. If they're not, that's when I really focus on like parent training and parent education. And like we spoke about, I usually use like my SPACE program for parents who have kids who don't have a desire to change.
Tell us more about this SPACE program, because this is the first time I'm really hearing about it.
It's very cool. It's something that I did not design. I've just been trained in. It's at the start, at its core, it was to help children with just anxiety in general. And we know that kids with ARFID have anxiety around food. That's just pretty much 90% of the kids that have ARFID are going to have anxiety around food. So it started with just helping kids with social anxiety, general anxiety, and then there are now courses in SPACE that focus specifically on ARFID. So I really help parents just with the ARFID piece and the anxiety piece. But what it's really doing is helping parents identify whatever accommodations they're making for their child and teaches them how to reduce those accommodations while also supporting their kids. So it's not, it's not like a starve it out method or anything like that. It's looking at what you're doing for your children that are kind of contributing to that avoidance cycle and how to stop that cycle from happening.
What would be a few accommodations that parents often make and not realize it?
That's a really good question. So the most common ARFID accommodations are, of course, like cooking a different food for your child every night. That's probably the most common. A lot of times it's, wow, I still have like a bag that I'm packing for my kid they're 13. We have like a diaper bag of like snacks. We pre-eat before parties. I make sure that I have like, maybe they like Cheerios or whatever. The pantry you'll see has like 20 boxes of Cheerios because they don't ever want to run low or they don't want to ever run out. Other accommodations are like only going to a restaurant you know your child will eat at, which gets really annoying for siblings because sometimes it's like, why do we always have to go to like Jimmy's favorite restaurant? This is so unfair. Or maybe like reheating your child's food 5 times because it always has to be like a certain
Oh my God,
level.
yes.
That's what big ones do. I know. Yes.
I mean, we hear these all the time, and sometimes parents are like, oh, they're just picky, but then you're like, there's something more to it than just picky. But you're right, like the accommodations,
Yes.
they are like, it can get really intense and very kids. Well, and this is where the hard part of like in what we do is because there could be underlying anxiety, but then you really run into that behavior component and habit.
Yes, exactly. And it all meshes together. And, you know, accommodations, I'm a parent too. We love our children, right? We want them to be happy and successful. So what ends up happening is, oh my gosh, this food is causing my child to gag, or this food's making my kids so uncomfortable. So what the parents do is accommodate and remove it because we don't want our kids to go through that stuff, right? That's awful to see. Or, well, if I get a different pizza, they're not going to eat and then they're going to be hungry. Nobody wants that. But what happens is the more we accommodate, the child just kind of learns like, well, when I avoided, mom was like, all right, well, you're right. You should be scared of that food. I'm going to remove it for you. Like, here, let me make you feel better. Instead of helping you learn how to gently push through it, they just remove it. So then their child is like, well, I feel way better now. How do I feel better? It's because the food was removed. So every time you do that, you just reinforce that cycle of avoidance, and that makes ever growing really, really hard.
I have two questions, but the first one is, we know that ARFID and autism they can often overlap or coexist, right? Do those cases tend to be more difficult, or how do you navigate those cases when it's autism and then ARFID?
They're definitely more difficult in many ways, but I will say, even if you have an autistic child or an autistic teenager, anything like that, if the level of communication is not really delayed, like if you're able to communicate effectively, then you can use similar strategies that you use in space, that you use in feeding therapy like that. If the communication is impaired, that is much more challenging, right? Because we're using words to help kids kind of get through a lot of this anxiety. And if we don't have that communication back and forth, that can be really, really hard.
And then the other component of that is because these parents are with these children all the time, or caregivers or teachers or whoever, do you know of any resources that parents can go to learn more about how they can help their child?
Yeah, there's lots out there. I know that feedingmatters.org is a huge advocate for eating disorders, feeding challenges, everything like that. I usually reference that site. They have a wonderful support system and support network. There's also some Facebook groups that are really supportive and have a lot of good intention behind it. There's one called ARFID Family and Caregivers. That's probably the most popular one. And there's just a lot of people sharing their story, a lot of parents giving support, giving advice. And so I really like that as well.
I have a couple of patients now that we're navigating the selective eating, no diagnosis yet suspected, but something that has been coming up more so with these preteen and teenage groups is the use of ADHD medication, and then how that interacts or affects the hunger and appetite and the psychological components and desires of eating. And I've even seen with my own daughter change in taste buds. So how do you ever navigate that?
Which is really, really hard. And actually, I had a little guy, and this kiddo was littler, but his dad is considering medication for his ADHD. And he had that specific question. He's like, he's already pretty restrictive with his eating, then how is this going to affect it? So of course, we don't know until he starts the medicine, right? But you can obviously assume, right? Because that's a huge side effect. What I told this dad is what I tell a lot of families is, when we're dealing with something like ARFID that's already restrictive and then we add a medication to it, what I focus on for those families is really volume of their preferred foods. And at that point, I might step back a little bit on like food expansion, because it's so crucial that they're getting calories. When we're kind of adjusting to these new meds and kind of getting a new norm, I don't want to be pushing like itty bitty bites of strawberry and making things almost worse if they have like no desire to eat or explore. more. So really for those, I'm working on their core foods and getting bigger volume of those core foods.
Okay, so for people to understand that the medication, definitely, I think people forget that these medications affect appetite. They reduce your motivation to even want to try new foods, especially if you're already selective.
Yes.
In these situations with summer coming up, I'll talk to parents about reaching out to their psychologists, psychiatrists, pediatricians to see if we could maybe plan feeding therapy with a break during a break of the meds or whatever it is, just to see what are our goals.
Exactly.
Because parents are so like, but I want the change right now. And it doesn't happen that way.
And it takes a while. It takes a while.
Honestly,
Yeah,
even
it can take a long time.
It does. It could take I feel like it takes 2 to 3 months to be off of the medication to finally
for sure.
feel back to normal.
Yes, it definitely does. When you're thinking of a child that's already restrictive, then maybe you have an ARFID component, maybe you have an ADHD component, so you've been focusing on eating as hard. And then you add a medicine that makes you less motivated and kills your appetite. If you even continue the volume or increase the volume of preferred foods, that's like a win to me, right? If you're not losing calories and losing weight, that's a huge win because you're already battling all these other things. You can't battle everything at once. You just can't.
Yeah. So that's another conversation of when you have an eval and you talk to a parent about the timing and how the treatment is going to work, because it's not going to go as quickly as they want it to go. There was something, regarding earlier on with the diagnosis of ARFID. So what are some of the top characteristics that you often see when you are like, yes, other than the anxiety part, but like, you know, the amount of foods that they're eating or something like a little bit more information towards that so that our parents know or can at least question, is this ARFID or is this behavioral? Is it chewing, right? So yeah, if you could give a little bit more information on that.
Yeah, of course. And remember, it can be a lot of times when our kids are really little, they could have like an underlying GI disorder or an underlying chewing difficulty that does turn into ARFID just because they've been refusing for so long. So we do want to kind of be mindful of that. But really, it's that anxiety piece, the strict, hard refusal for trying anything new. It doesn't have to be that they're underweight. I have plenty of kids who are actually overweight or meeting their growth goals and still have ARFID. Because a lot of times if you're eating pasta all day, you're still going to be pretty big, right? Your nutrition might not be being covered, but to like the naked eye, you're like gaining weight, right? So it's not really a weight gain. It's a more, wow, am I restricting a whole entire food group? Can I not literally do anything wet? Can I not even bring myself to lick or take a tiny bite of a new food without a complete meltdown? And then a really, really big one is the social isolation. Is this affecting the person socially? Are they not going to summer camp? Are they not going to birthday parties? Are they eating by themselves? Can they not go out to eat at restaurants? Can you not travel? I have so many parents that come to therapy because they're like, we cannot leave this country because my kid only eats McDonald's, and even if they have a McDonald's in France, it's going to taste different. I know they won't eat. So that level of restriction is what is like hallmark red flags of ARFID. It's that crazy kind of like, I feel like I'm in a bubble and I can't get out.
Oftentimes when I get calls to see if their child will benefit from therapy, one of my big questions is, well, how is it affecting your life? Because I find that I get more buy-in to go through my therapy process when a parent is like, just like you said, we can't travel, we can't go out to eat, you know, we are constantly having meltdowns, we don't go to birthday parties. And then finally parents are ready to get help. And I think what's so hard in my brain as a therapist is all the red flags were there. They've been there for years probably. And in some of these cases, my big focus with the younger groups, like the babies and the toddlers, is that if we're seeing red flags in babies or toddlers when they're transitioned into solids, I encourage parents to get help then so that it doesn't build up.
Right, so you don't get all those usual behaviors and it grow into something way more. Because the early intervention is really, really important. It's huge with the whole feeding because you're basically starting to see some of those refusals right around the time when they're only like 1, when you're starting to transition from like the really smooth purees to like, now it's bumpy, now they have to chew. And that's when you get like some of the gagging, which then parents see someone gag and their anxiety goes up and then they remove the food and then that food's gone and then the funnel just gets lower and lower. So that's a big part of it.
Yeah, I mean, I'm sure we both see that it's like these parents are like, this didn't just happen overnight. They know that it's been going on forever. And so a piece of advice that I always, that either we provide or that, we encourage our parents to tell their friends is to get help early on. But how do parents, I mean, how does a parent in your area find you? And I would love to know more about your intensives.
So I'm in a lot of local Facebook groups, Instagram, everything. So they usually find me through social media or word of mouth or some local Facebook groups. I can give my website at the end of this. And you can always contact me through my website too. So the feeding intensives. So that really is, I do have a with us in there. It's me, another speech pathologist. And there is a BCBA if we need sort of some help with regulation and things like that. And we see them every day, 4 times a week for 1 hour a day for 6 weeks. So usually those kids are a little bit more severe. Most of those kids that go through intensive are kind of the 4 or 5-year-olds, like our most recent 2 that we just had. 4 and 5-year-olds, both of them did have an autism diagnosis, and both of them were only drinking from the bottle and not eating any food. So I do have kids that are like 4 and just still on total Pediasure. So that's kind of the level of intensive. They were medically stable. So I won't see kids in my intensive that are like, okay, we're looking at a feeding tube situation, or you need a partial hospital program because they're so medically unstable. So my kids at this level, the level that I'm at, they are medically stable, but literally it's just bottle all the time, nothing else.
Okay, and do you have a dietitian that'll sometimes work?
We have a dietitian that we consult with. She doesn't come into our sessions, but if we need help or guidance, then we can have one-offs with her. And then I have a GI physician that I will refer to. Most of these kids have been to GI because by the time they're 5 and they're like still just on the bottle, they've probably had swallow studies, which didn't do anything, let's be honest. And then they've probably seen GI and they might have had a scope, and some of them probably will have had blood work by then as well, just to make sure that there isn't kind of micronutrition gaps. So I do have, I have a GI. I have an OT that pops in also. My SLP, I have a BCBA, and we do have psych if we need to referral for that, but these kids haven't needed that for the intensive. Psych hasn't been a component.
And will you run these 6-week programs like most of the year, or is it certain periods of the year?
Yeah, like our next one is starting June 8th, and it'll go for 6 weeks with a break off for 4th of July, but we usually don't have that. Usually they're consecutive 6 weeks. So since the start of the year, we just finished our second 6-week intensive, and then we're going to do another one in June.
Are parents in the session, or do you give homework? How does that work?
Yeah, we do have homework, but usually the first 2 weeks, it's like me or the therapist, whichever, and the child really building rapport, understanding this is what's going to happen, everything like that. The second 2 weeks are really me and the parent together, and then the last 2 weeks is really the parent doing most of the feeding. So I try to transition it to simulate getting it to generalize to home, but obviously that's in a perfect world. Like, it doesn't always go like that, but that's kind of the goal. And then because it's only Monday to Thursday, so the Friday, Saturday, Sunday is when a lot of the homework takes place. Like, hey, this is what we did all week. I want you to do this for 3 days over the weekend and let me know how it goes, and then we regroup on Monday.
I love that you do this. Goals, absolutely, because we know that for some of these severe cases, and I have this conversation with parents and other professionals all the time, that in some of these circumstances, we need every day. Once a week is not going to do it, and there's going to be cancellations. I have a parent recently that was like, can we just meet once a month? And I was like, absolutely not.
It's not going to do any good, right? What's the point?
I think what's hard is that parents, and I'm a parent as well, with a lot of my children's activities, I still have a tutor. I used to teach swimming. That doesn't mean I want to teach my kids how to swim. I'm going to hire the swim instructor. They're going to listen to the swim instructor better than me. So I usually give that analogy of it's the same for feeding therapy. Your child will build that rapport with me, and our goal is to translate it to you. If we are eating in therapy and they're not eating at home yet, something is not going right.
Exactly. There's a miss somewhere. And sometimes with those kiddos, I will sometimes say, hey, like for this session, let's do it virtual. And then I want you to do everything and I'll just be here as like a guide. So to help transition that to home. And even in my clinic, I shut the door. I have the parents do it and I shut the door and I'm like, if you need me, let me know. And if there's a meltdown that happens, I go in. But I run whole sessions with parents doing everything. Because if they're just eating for me, that's not helpful. That's not going to do anything.
No, but it is like on the pro side, because I see kids at school too, where I'm like, you are eating all this food at school. You refused this with a temper tantrum last week.
That's the most frustrating when you see them doing it and you're like, with those situations, because I do get that a lot, I always kind of coach parents, like if this, say it's pears or whatever it is, and they're having a meltdown at home and you see them do it at school, that's a food that I'm willing to push and I'm gonna like die on that hill because you know they will fine with it. So different from like something where you're like, oh my goodness, could they really be having like a visceral reaction and horrible sensory things? But if they're doing it, that's the food that you wanna push through that behavior with and be like, we're good.
I love hearing that because I think parents still get so scared. They get so scared of everything. And I'm like, we have to parent. Like, we have to put our rules down. And that actually goes to a really interesting, you hear a lot nowadays of, okay, like some of the people who talk about, I decide as a parent what goes on the table.
Oh, like a division of responsibility. Yes. So I'll decide what I put on. Yes, exactly. And
that's, but you decide how much you're going to eat, and then there's a safe food there. But what do you do with these kids with ARFID who, a parent says, I have a 1-bite rule, even if that results in tears?
I don't do the 1-bite rule because it doesn't work. Because
although it's not effective long term,
you do get them to do the bite, which let's be honest, we probably could get them to. They're taking it like medicine. Like they're not learning anything about enjoying food or anything. And if they're in a state where they're being demanded, like you have to do 1 bite, I can almost guarantee you that kid's not going to be like, oh, you know what, Mom, you were right. That was amazing. Even if they liked it, kids aren't going to do that. They just aren't. That's just not how we're built. So what I kind of like, I do like aspects of division of responsibility, but I think there are some gaps where parents don't have that support. So if you are to kind of learn space, like we talked about, it's that same foundation of division of responsibility, but gives you all the tools for what happens when I do this, what happens when I do that. I still want to support my kid. I still want to be very, very supportive. How do I do that and then not be accommodating? So space is kind of a blend of the two. Personally, after getting to know you, I think you would like it. It does kind of give parents the freedom to say, hey, I can have boundaries. I'm allowed to say no. If your kid is only eating cookies, it is okay to say, well, we're not having cookies for dinner tonight, right? You can do that. So it does give you that kind of, as a therapist, that sort of background and the information to say, hey, I'm allowed to have boundaries and expectations. And then you can pass that on to your families too. And they're allowed to do that as well.
But at the end of the day, the forcefulness of that 1 bite, a parent may think they're being successful, but it really, it actually can really regress you.
Yes, and it has to do with what is the definition of success. Like, okay, cool, you got them to do it once, but did you really make any change? No. So,
no, and everybody feels awful. So
it's horrible. It's just a miserable experience. Yeah.
It's so, and if parents ask me, well, what do I do at mealtime? Well, number one, dinner is like the worst time to challenge your child.
Of course, you're probably tired. They're tired. Everyone's done.
No, I am like, can we just do breakfast or lunch? Like, why does it have to be dinner?
Weekend, like something where it's like chill.
Yes. Yeah, so I always feel like that's a good takeaway. What would you say another good takeaway for our parents would be?
So, I know that there's a lot out there if parents are kind of looking at social media and it's all about exposure. And then you'll hear parents saying, you probably hear this, but I do expose them to it. They've seen it 50 times. You're still not doing anything with it. So what I kind of say to that is I still think it's great to have foods out, exposure, everything like that. But what I always show my parents is like, parents' their goal is like, success is them eating, right? And like they're not eating it. So they don't do any of the steps in between. So that's where I think that's why parents bring kids to us, right? They want you to do all the steps in between, but they have to do those steps in between at home. So picture of it like a ladder, like not eating and then eating. There's probably 25 things in between that you could do. And parents don't usually do that. A, because they don't know how, and B, because it's time consuming. So what I do in therapy is show parents all the things in between, and you can do those at home with your kids now. Like, hey, cool, it's on your plate. Well, let's see if we can kind of stab it with our fork, get some residue, and then just like touch the residue to it. Oh my gosh, that was so easy. Like, you want everything to be really underwhelming so your kid is having success and success, but it's so easy for them. It's nothing hard. If taking a bite is hard, then make the task a lot easier. So they're like, okay, and then you progressively make it more difficult and challenging, but they're starting to trust their body. They're trusting they can handle things. And you're like, yeah, I know this is hard, right? They're crying maybe even at a point, but you can do hard things. So you're making it easy enough that they're making little steps in the right direction, but they're learning it's not all that hard and that they can do it.
I love that. And when you talk about the steps in between, my mind goes towards the SOS approach.
Yes.
Which I want my parents to know about. I know it's not. I've built in my own business and my own feeding therapy so much past that because, again, we know that one bite doesn't get us very far.
It doesn't do anything.
And interaction with food is important.
It's interaction. It's learning those steps in between, and I agree. And when I start it, I always kind of tell my kids, like, okay, yeah, right now we're not eating it, but this food is for eating. Food is not for playing. We are not just going to only lick it for several times, right? We're building up to eating. Because if you tell them, no, you don't have to eat this, you're just gonna, put it in your mouth and spit it out. Well, that's okay now. When you do expect them to eat it, they're going to look at you and say, you said I never had to eat this. So you don't want to kind of set anything up for them being able to turn that back around on you. So I always do preface it with, hey, blueberries are for eating. Today, we're just going to cut them open and taste the juice.
Yeah. And it's like baby steps. That's exactly baby steps. And a big thing that I often tell my families is I call it like food friendships. And it's all about like make friends with the food you love can make friends with other foods. They don't have to be best friends. They might not even hold hands. But like if that person is always outside the door, you're never going to get to know them. Mm-hmm. And I feel like it starts to like, okay, like can we at least like sit on the seat next to each other?
I might steal that from you.
Take it by food friendships because parents will often say like, I can't even put the carrots on the plate. And I'm like, okay, well, can they go on the table? And can your friend get closer?
Step. Like, yes, there's always a step that you can do. Exactly. Instead of just removal. That's what you don't want to do. There's always a step you can do. It can get to the point where parents sometimes are like, this is silly, like, right? But it works. And the other thing, I had this great mommy yesterday, actually, and she's wonderful, but she has a little bit more of like a flatter affect. So she was like, I don't know, like he's doing it, but it's just like, and she was just kind of lost and all this stuff. And I looked at her and I watched her for a few minutes and I said, just very candidly, I'm like, are you like celebrating and getting excited when he's doing these things? Like watch me when I work with him. It is like such a big deal when he like eats a couple grains of rice or whatever it was. And she's like, no, well, you know what? It feels kind of weird. So like we had to actually practice her like celebrating with him, things that she didn't see were a big deal, but to him. And then he started laughing and he was so calm and he thought it was hilarious that she'd give little tickles when he was doing these things. So like, I think that that's really important too, how we react to our kids and just kind of showing like, hey, we do understand this is a big deal for you. This might be hard, but you can totally do hard things and I'm going to celebrate you.
Our babies really do love us and they want you to be proud of them.
Yeah, they do. They think it's great. They think it's awesome.
I think that is a really, really good tip for parents to hear, that those baby steps could be really hard for your child, but they're trying so hard to please you. And I often will encourage both mommies and daddies or partners or whomever, grandma, babysitters, like everyone kind of has to be on the same page of how they react to the child's, how they react. I want to say the anxiety component of the child.
Yes, for sure.
So, okay, with that, because that was awesome, I feel like we addressed a lot of good takeaways for ARFID. Yes, tell our parents how they can find you.
Oh, sure. So you can email me, Kelly, Kelly, at food4thoughttherapy.com. Or you can check out my website. You can schedule, book a call with me, or you can just explore my website. There's lots of good information, and there's some blogs and things on there. That is food, and then the number 4, thoughttherapy.shop.
And I'm going to put some of this in the show notes because we hit on so many topics. And to close, what would be, one takeaway for parents to start moving forward, in the next week or so?
So I would say when your kid, like we kind of just talked about just now, if they are refusing, you're frustrated, everything like that, I think it's way more important to keep that food and keep it somewhere on their plate, keep some level of interaction with it, as opposed to just removing it. Because once you remove it, then you're just going to kind of get into this huge cycle of, I felt better when it was removed, and now you're feeding into all that anxiety. So the more we can just baby step outside of that safety bubble, is going to make huge gains in the long run for your kid.
And I would add that would even start with our babies.
Yeah,
because
it does.
Parents will be like, they ate strawberries today and they kept throwing them today. And I'm like, we gotta keep.
Yep, do it again. Because, and one thing I can tell parents too, whether in feeding therapy or not, it's not like a straight trajectory. So like with the strawberries, that's great. They're eating strawberries. Awesome. I totally expect a baby to then be like, I don't like this today, right? That's really normal. It's gonna go like a roller coaster. You just want it to always be trajectory is like up. But it's okay if you have good and bad days. You just don't want those bad days to be like, oh, you didn't do that all yesterday. I'm just not giving that to him anymore. You want to give it again with just the expectation of, hey, this is your food, this is lunch, don't make a big deal.
And at the same time, I do sometimes eat the same thing over and over again, but then I do switch it up.
Oh yeah, and you have good days and bad days.
Yeah.
Right? Like everything. So it's normal for our kids to kind of
And how we sleep. And
Yes.
how much we're getting, whether we're still on a nutritional supplement or our bowel movements or
Yeah, if they haven't gone to the
medications.
bathroom, their tummies and whole GI system are like really tiny. So if they didn't go potty, there's not a lot of room for new foods. And so we
No.
wouldn't expect them to be as open on those days for sure.
And it's all like, I often will say, like, is our GI in check? Like, are we working? Because if we're not working properly, then things are not going, your mind is not going to want to eat those foods.
There's no desire. And you're already faced with someone, if you're seeking help, you already know they're like more on the resistive side. So then if you add a GI component in there, it's just like the perfect storm for food refusal.
Yeah. But thank you so much, Kelly.
Of
I
course,
appreciate
thank you for having
it.
me.
As Kelly said, Food for Thought is her website. She runs intensive feeding programs, which are sometimes really hard to find. And, reach out to her. And I'm Jean Hawney with Little Eaters and Talkers. I am at thelittleeaters.com. And let us know if you have any questions. Thank you.